Welcome to Voices in Health and Wellness, where we connect with health leaders, clinicians and change makers, redefining what care looks like in today's complex world. I'm your host, Dr. Andrew Greenland, and today's guest brings a unique lens to that conversation. I'm joined by Dr. Danielle Esler, Chief Medical Officer at Misty, a digitally enabled women-led healthcare platform focused on accessible team-based care. Danielle is a dual specialist in primary care and public health with more than 20 years of experience across clinical medicine, health policy, medical education, digital health and AI. She's held leadership roles at the national level, including as Deputy Chief Health Officer in Australia, and now splits her time between the US and Australia. Danielle, thank you so much for joining me today and welcome to the show.
Thanks so much for having me, Andrew. I value the opportunity to have a chat.
Lovely. So maybe we could start off just a little bit about your journey. You've had a very interesting career. You've got a very interesting portfolio. How did you end up doing the various things that you do, from the clinical work and public health leadership in Australia to your current role as Chief Medical Officer at Misty?
So when I studied medicine at Monash University in Victoria in Australia, it was very much the traditional disease-centric focus and hospital-centric education. And sometimes life just draws you via its own path. As a new doctor, I married another doctor who had a return of service obligation to the Royal Australian Air Force, and he was posted to Darwin in the Northern Territory. I know this is a global audience, so a bit of context about the Northern Territory. It's approximately twice the size of Texas, with a population of only about 200,000 people, and a significant proportion of that population are Australian First Nation Aboriginal people. So Darwin, the capital, is a very remote locality, about a 4-hour flight from Sydney or Melbourne. And the as an early career physician or doctor, this really informed my perspective on health. So when we first moved there, and this was a long time ago now, I did train in general practice in an Aboriginal community-controlled organisation. And so that practice really focused on chronic disease, significant burden of diabetes, for example, in the Aboriginal population, but also with a strong tropical health focus as well. And I really felt that more could be done at the health system's perspective to assist patients. So then I combined my career by bringing in another specialty, which was public health medicine, and I trained for that in the Northern Territory and as we moved around various Australian localities. We moved back to Melbourne at some stage, and so I ended up working in more traditional urban settings. But back in 2020, right at the beginning of the pandemic, before we knew the pandemic was coming, I went back to the Northern Territory to reconnect with my public health roots. And as you can imagine, that was a unique time to be reconnecting with a public health job that was working for the Northern Territory Department of Health. And so I worked in a leadership role for the pandemic, including as the Deputy Chief Health Officer of the Northern Territory for some of that time, really being involved in what was one of the most successful pandemic responses in the world. And so I'm really proud of that piece of work. Sometimes, again, life has other ideas, and so I'm a mum of 3 kids. We have complex health issues and disability in our household. And so a couple of years ago, we made the decision to move or spread our time between the United States and the Northern Territory of Australia to meet some of those additional needs in our household. So at the moment, I'm spending 9 months of the year in Tennessee, and 3 months of the year in the Northern Territory. And that was a wonderful opportunity for a career pivot. I've been excited to be involved with a respiratory device startup, Misty, which is a Melbourne-based company, and I'm able to anchor some of the US focus for emerging markets there, as well as support their work from an advisory perspective in Australia.
Amazing. Such a portfolio. So we've got much to talk about on this call. Let's just quickly start. I know we've got some things that you particularly want to talk about, but let's start with Misty, because it has such a clear mission around equity and access, particularly for women in priority populations. What excites you most about the model and its potential impact? And perhaps just a little bit more information about Misty for those that don't know about it.
Yeah, so Misty, the Misty is their primary device. We're at seed stage startup, and a exciting device that provides hospital-grade respiratory care anywhere, anytime, and that uses novel technology that generates a mist and the potential for a broad range of therapeutics to be inhaled into specific areas of the lung. It's breath activated, hands-free, not connected to wall-based power. And so as someone with a rural and remote focus, the potential for, in particular, hospital-grade respiratory care anywhere, anytime, and with connected care using smart technology as well, I can just see the vast potential there, and I'm so excited to see where that company goes.
And just very briefly, for people that might have heard of a nebulizer versus the device that you're talking about, what will be the main differences?
So I'm an asthma parent, which is one of the other reasons I was drawn to Misty. And if we think about asthma, the standard of care is actually a spacer inhaler. You have to hold that on. I'm thinking from a pediatric perspective, hold that on the child's face. Some patients will require a nebulizer, and when my son was younger, he just didn't get the response from the spacer, and had used a nebulizer, which is loud, sensory. Patients are tethered to the wall. So this is hands-free, quiet. Patients can remain mobile, and for particularly children or patients with sensory issues, that's particularly appealing. But the technology related to the mist generation is particularly exciting in that there's a range for generating a mist for a very broad range of particle sizes. So for traditional asthma medications all the way up to biologics or potentially mRNA. So that it's really the sky's the limit in terms of what's possible there.
Thank you for that clarification. You're also involved in medical education and clinical AI consulting. What's the through line for you across these different spaces?
Really, for me, it's about optimizing impact. I've had an extensive career now in a range of settings, and obviously as AI is coming to the forefront in healthcare, I really value the opportunity to bring my voice to that space, particularly from a patient safety perspective. I'm concerned about the potential for bias from an equity perspective, and I'm aware that my career has brought a particular niche perspective to rural and remote health, disaster preparedness, Aboriginal health, and health systems. And I've been fortunate to have the opportunity to consult to a range of companies in that capacity.
Thank you. So let's go on to the meat of the conversation, which is the disaster preparedness. When we spoke earlier, you mentioned you had a deep interest for this, especially from the level of patient-clinician interaction. What sparked this focus for you in this area?
So I've already mentioned my asthma kid, and back in 2011, he was requiring a nebulizer, so a power-based device, and we had frequent hospital visits for him when he was a young kid. Fortunately, he's grown out of the worst of the asthma. So Category 5 Cyclone Yasi was headed to where we were living, which was North Queensland at that particular time, or hurricane for my US friends and colleagues. And I woke up really early in the morning. I knew that a Category 5 cyclone was likely to interrupt power and interrupt hospital services. And I I just thought, well, before they called for an evacuation, we need to get out of here. This is not a safe place for us. And so as I was booking airline tickets, just trying to figure out the best route out of town, the price was going up and up and up. So in the space of really 15 minutes, that normal sort of checking to find the best airline ticket that you do when you're buying a ticket, usually the price was doubling. So that really, I guess, was a learning experience. We got out. Of course, while we were in our evacuation point, which was Sydney at that time, my child did have a severe asthma exacerbation, and we needed the nebulizer. Didn't need a hospital admission that time, and so we made the right call. But I was aware that that there was no health systems advice from us in the patient space, and so now, as someone that lives across 2 countries, we have. It does feel like another job for me sometimes. My health systems caring role with my kids with a variety of conditions. Never once have any of our clinicians talk to us about what we should be doing in a disaster. It's not factoring in to those clinical consultations at all. I've been involved as a public health physician in disaster response and disaster preparedness. I'm very familiar with the global landscape, and I'll just mention that the Sendai framework, which is the global agreement related to disaster risk reduction, that has an understanding or a global understanding that this preparedness will be happening in health systems, but I think it's just terribly underdone. So I'm a strong advocate for improvements in that at the clinical interface and from a policy perspective for people with particularly chronic disease or disability, but even with emergency presentations, people are discharged often to heat waves, or in our instance, we were discharged after a significant emergency presentation right into a blizzard situation. And I'd just love to see these discussions and preparedness brought into the clinical space to support our patients.
Thank you. So we often hear about disaster response at a government or a hospital level, but what does it actually look like in primary care, particularly for people with complex chronic conditions? You've kind of touched on a few areas. I'm just trying to get a sense of what you're actually doing on the ground. Yeah. So
from my work in general practice, chronic disease planning is our bread and butter, and that's how many GPs or primary care physicians spend their time. I would love to see a conversation occurring in that space that's tiered to the needs of the patient, but also the geography where they live. So, for example, someone having their asthma plan annually, just having a question of what are we going to do when it's a bushfire smoke day. And Australia's gearing up for bushfire season at the moment, and there's going to be a lot of bushfire smoke around. What are you going to do if a blizzard happens and you need to stay at home for 5 days? How are you going to access your medications? So I think there's not many clinicians that consider this to be part of the chronic disease planning. I personally believe it should be part of chronic disease planning for all patients, because disasters are becoming more common. I've been through tornado warnings, blizzards, floods, cyclones. If listeners reflect on their own experience, it's actually the norm for us to be exposed to various disasters. The pandemic, we've all had essentially stay-at-home orders under the pandemic, and the assumption that patients know what to do or families know what to do, I think is flawed. And we know that disasters don't impact equally. People with chronic disease and disabilities have much worse outcomes in disasters, and there are opportunities for clinicians to improve on that.
Interesting. I mean, do you have any sense about, I don't know how much knowledge you have of the UK, and it's a bit of an unfair question, I guess, but do you have any sense of what the kind of things that we should be thinking about in the UK? Obviously, we don't necessarily some of the extreme weather events that you've talked about, but what are we missing?
Well, I know you have heat waves. So, and you have floods. Look, you perhaps you can answer the question, because I'm not sure if the UK has a universal patient-held electronic medical record, like Australia has the My Health record, which means that patients have access on their device, and clinicians have access to histories wherever they are in the country. Is that something in the UK?
Yes, so we've actually moved to that within the last couple of years, and it's sort of gradually evolving. But yes, there is a national health record.
So the potential for that record to improve outcomes, and not just outcomes, but improve people's dignity and well-being in disasters, is considerable. And so ensuring that that's a resource that patients are aware of and using, and clinicians are using, and ensuring that the depth of information there is meaningful and can assist people, for example, if they need to evacuate and access care elsewhere.
And is there anything you're working on at the moment? Anything you're kind of forecasting or looking into the future and thinking, okay, we don't have a plan for this, or anything that you think there's a gap that needs to be addressed where you are?
I think technology innovation related to connected care and clinicians, patients, carers having access to information wherever they are is really important in terms of disaster preparedness, because whether someone needs to stay at home or shelter in place or evacuate, you can probably hear my dog in the background, sorry about that, or whether they're evacuating, they are separate from their usual care teams. And so connected care innovation, and Misty, I mentioned that's one part of the story there with that respiratory device. Just keen to advocate for that and be involved in spaces that are looking to do that. And then there's benefits, obviously, beyond disasters that translate just to everyday rural and remote care for connected care.
So you were talking about digital platforms earlier on, and I just wonder what you have locally and where you are in terms of platforms that support the work that you're doing, and how you use the information for your planning, because obviously we've just started to have more of a national record. I'm just curious to know how it's being used to the full in the kind of work that you do. So
I guess I can speak to the US setting, and again bringing the carer perspective in, and there aren't any universal held records here. It's a very siloed and fragmented system, so that, for example, if we need medication prescribed, the physician will send a prescription to a very specific pharmacy, and even in everyday life, if there are challenges with supply chains, there then becomes this to and fro with the physician and the pharmacy to try and find somewhere to access it. And so if you bring in displacement or additional challenges or worsening supply chain vulnerability, then the ability for patients to be able to access the medications in the United States is fraught and much more difficult than what I'm used to in the Australian system. So I guess just being part of discussions such as this and around this are helpful. I'm fortunate in that Nashville is a hub for medtech and digital health, and so really for me, as I'm splitting my time between two countries, being part of those conversations is where I'm putting my energy.
Thank you. And are you seeing any gaps in how clinicians are trained or supported when it comes to managing care during disruption?
Well, I think clinicians don't see it as their core business. So there are opportunities from a medical education perspective at all levels, from medical school and beyond, to improve capacity and confidence for multidisciplinary teams across the full range of specialties to be having these conversations and feel comfortable to do so. And it may be just as simple as training our doctors or our nurses to say, to assist patients in deciding whether a shelter in place or an evacuation pathway is the best option for them with their particular medical problems and the particular hazards they face where they reside.
Thank you.
Mm-hmm.
So if we take your sort of day-to-day, what does your day-to-day look like at the moment? I know you've got various interesting things that you do. What's a typical day or week like for you? And I dare say that no day is typical, but I'm just want to try and get a sense of where you kind of focus your time.
So because at the moment, my Australian health expertise is very much the anchor in terms of the opportunities that are presented to me for consulting, for example, and for AI work. So that does mean that I'm working to the Australian time, which is in the evenings frequently. Unfortunately, with flexible work, my evenings tend to be the busiest in terms of meetings for Misty. I'm heading out to the JP Morgan healthcare event in San Francisco next week, so supporting Misty at a variety of global health events. And I've had the opportunity to be really an adjunct position, a community fellow with the Belmont University's medical school and their health systems department. So I do have the opportunity for face-to-face teaching with medical students here in Nashville. Brilliant.
And is there a space in the curriculum for getting this important message around disaster preparedness from your experience in teaching?
So I'm not on staff there, but my colleague there is an expert on disaster preparedness, which is why he's invited me to become involved with the Department of Health Systems. And so I'm sure he is flying the flag for disaster preparedness. My next talk is on health in the built environment. So social determinants of health are obviously the broader umbrella in which this sits. And so I'm having opportunities to contribute in that space.
So what do policymakers misunderstand about disasters and chronic illness from your perspective?
So I think they underestimate the need for really integrated disaster preparedness. And the Sender framework does call for that. And if I could just use an example of how potentially different departments need to be working together from policy. So in the Northern Territory, we have significant season of bushfire smoke where the bushfire fire risk may be remote, but there's heavy smoke, and we know that that's terrible for people with respiratory disease. So my team would be issuing bushfire smoke advisories. I might be asked to speak on the radio about what people should be doing in terms of avoiding the bushfire smoke if they had respiratory disease, and yet I would then find that the schools would be still scheduling their athletics carnivals and having all of these children out running their track and field in the bushfire smoke, and I'd be left as a parent to make decisions about what I should be doing for my own child, which was obviously keep them at home that day. So the need for integration and use an emergency management framework does look to bring the policymakers and the various departments together. But in that preparedness phase, I think that coordination is absolutely key. And also considering disaster preparedness as core business in health. We know that the drive is often to reduce emergency department visits, and investment in doing this will reduce emergency department visits.
Thank you. And you've obviously had experience of the US and Australian systems. I mean, how do they differ, and what can they learn from each other, from your perspective?
Well, I've mentioned that striving for interoperability and the universal handheld medical records, and I think the Australian example is really a strong, positive global role model for that. Integrated health systems are needed at all times, and I've definitely found that that's a lack here in the United States as a parent of kids with complex issues. I'm not sure if that answered your question.
It does. No, thank you very much. What are the biggest challenges in the work that you do? I don't know, is there anything particular you've had to really overcome in this work, or is there anything like a big hurdle that you're trying to overcome in this field?
Well, I mean, this is a personal challenge, and many professional women in particular that are listening will understand that women's careers are not linear, and we often have competing demands. And so when I was in a senior leadership role as the Deputy Chief Health Officer of one of Australia's jurisdiction, it was easier for me to impact. As someone that's had to make some complex changes, it's just my knowledge and my ability to inform decisions and in relation to this is still there, and just seeking pathways to amplify that message sometimes is harder outside of the sort of clear government frameworks that I worked in for so long.
Thank you. And looking 6-12 months down the line, what's kind of top of mind for you? What does success look like personally and professionally?
Well, I'm looking forward to spending the Australian winter, the US summer back in Australia, and seeking really to optimise my impact there from a what I would describe as a mainstream health perspective, but really seeking opportunities to amplify my contribution in this space, and in particular the corporate space in the United States. I'd love to have pharmaceutical and device companies really understand that there's market value in disaster preparedness, and that smart companies will be investing in this as we move forward.
Thank you. If you had a magic wand and you could change one thing in the way health systems prepare for emergencies, what would that be?
I would just love more conversations happening at the chronic disease care planning space between patients with chronic disease and their primary care providers.
And if a natural disaster or major system failure hit tomorrow, what do you think would break in the average clinic or care model?
What would break? Look, access to medications is a particular concern, from supply chain up to individual access. That I'm particularly worried about that.
Okay. And have you seen any sort of surprising resilience strategies from individual patients that you've worked with, or any local care teams that we should all be learning from?
Well, I am aware of work that was being done from the asthma peak body in the Northern Territory, and where they had a phone line for asthma education, and those asthma educators very much had bushfire smoke as a health risk front of mind in their asthma education discussions, and they were saying that they did have a subset of patients, certainly not in the majority, who had that risk of bushfire smoke front of mind and were being proactive. So people that are listening who have their own chronic conditions, as I know many will, would really advocate for don't expect your clinicians to be bringing disaster preparedness to the conversation, but I'm sure that they'll be willing if you bring it yourselves.
And if you were starting again in this field today, knowing what you know now, what would you approach differently, if anything?
So my career's been really organic and with competing demands of, as I mentioned earlier, at one stage a military husband and now kids with health issues. And actually the organic nature of my career has led to really many beautiful professional moments and has engendered a unique and niche career, which is turned out to be my strength at this stage of my career. So I can't really say that I'd change anything. I think being willing to embrace the opportunities professionally as they present themselves. I never in my wildest dreams would have expected to be in a leadership role in a pandemic. And we don't want bad things to happen, but being willing to step up when they do is important.
Thank you. And with that, Dan, I'd like to thank you so much for your time on this podcast. I really appreciate the depth and clarity you've brought to this conversation. I think these are topics that often get overlooked until it's too late. But I think your work and your conversation shows just how essential it is to build preparedness into the DNA of care at a systems level, but also at the patient level. So thank you so much. Really appreciate it.
Thanks so much for the opportunity to discuss these issues, Andrew.
Thank you.